Before I introduce you, are doing great things in the world that I think you should know about. My guest today is Chad Bonfiglio from Datar Cancer Genetics. And let me tell you a bit how he came to be a guest on the show. If you watch the show regularly, you know that probably 95% of the guests are referred by past guests. And even though he wasn't a direct referral, this is what happened. We had Dr. Dawn Musalem, who is a plant-based oncologist at the Mayo Clinic, on the show, telling her amazing story about cancer recovery and running marathons. And she had talked about something called a liquid biopsy. And I didn't quite really know what it is, but that's not what the show is about. But it was kind of in the back of my head. Oh, this is interesting. But then Dr. Sunil Pai, who has a regular show on this show, talked about a conference he went to about cancer specifically. And he was telling me, because his show was not about cancer, it was about spices actually, but he was saying, I went to this conference and there's this company and it's really interesting and they can diagnose a cancer with a simple blood test. I'm like, come on, he goes, no, it's true. So I contacted the company. And Chad works for the company. He's going to tell you, and he's going to talk all about this. It could be revolutionary, especially for a lot of people that maybe cannot get biopsies or don't want to get biopsies. And he's going to talk about a revolutionary cancer diagnostic, treatment, and remission monitoring that is done with a simple blood draw. Please welcome Chad to the show. It's nice to meet you, Chad.
Thank you. It's a pleasure. And thanks for the wonderful introduction.
Absolutely. So, this is like a lot of people will say, come on, blood tests. I mean, why don't I know about this? If this was something my doctor, my oncologist would have told me.
Sure. And I have a number of reasons that doesn't occur. It doesn't occur yet. But the primary reason is that physicians aren't educated on newer technologies at the level that they used to be. Additionally, insurance coverage is not covering all of these tests that are on the market and all the opportunities that people have to receive better cancer care. So there's a myriad of reasons. Also, the groups, the colleges, say the American College of Obstetricians and Gynecologists, they're slow to kind of update what recommendations they have. And this is what trickles down to the average provider. And additionally, providers just don't have time to keep up on research like they used to. And that's another major metric as to why these things are not as prevalent as they could be.
That's so interesting. Now, a long time ago, Dr. Doug Lyle, who's a regular on the show, told me something about, it's called Oncoblot. Is your technology similar, better, different?
No, Oncoblot, I don't know if the company still exists, but that worked on identifying a protein called the ENOX2 protein. And if that protein was found, it was believed that you had cancer, but at the time it was very non-specific. And I know that the founder who had done that research passed away, so I don't know if the product still exists at all.
Yeah.
So
I know that you've prepared a presentation, which I think is great because I think people can really learn when they're visually looking at slides. I don't know if this is in your presentation, but who is this company and how did they start doing this work?
Sure. Datar Cancer Genetics has been around for about 11 years. We're currently up to about 450 employees. We distribute our products in over 40 countries. The company's a billion-dollar plus operation. Personally, I'm the director for the United States, so I'm responsible for all operations in the United States, which is one of the newer markets for us. And we base all of our research and all of our effort on removing the need for tissue-based products. So tissue-based biopsies, anything invasive. We wanted everything to be blood-based. And we're definitely not the only one in this space, but we have two technologies that are very novel to us and what we can do with them. So we're not the only player. I'm very candid. I'm happy to mention other companies when they do good work and make recommendations, because there are a few that do have insurance coverage. We don't at the moment, but that's something that's in process. So that's the brief history.
Well, that'll be amazing because especially, I mean, I don't know much about cancer, but I know that some people have tumors that are, like they say, inoperable or in a difficult place. And to get a simple blood test would be a lot easier for the patient than having, surgery.
Yep. And one of the key things that we have is that on the diagnosis side, we have 3 FDA breakthrough designations, meaning that the FDA was so impressed with our technology and our clinical trial work that they fast-tracked us for approval. And then we have those designations for brain tumors, prostate, and breasts. But we can actually identify 70 different types of solid tumors with our platform.
I mean, who developed this technology and how? Because it just sounds almost too good to be true.
In some ways, well, I wouldn't say it's too good to be true. It's kind of what the holy grail is that every company has been searching for. We just took a different approach. It was actually developed with a partnership with Worcester Polytechnic Institute in Massachusetts, and our team of researchers in India developed it originally. You had mentioned the availability, how prevalent it is in the United States. Candidly, Western Europe, Asian countries are much quicker to adopt new technology, much faster than the United States is. The United States is kind of a slow mover when it comes to adopting new things. That has some value because it often ensures something is good, not in every single case.
You know what? Your sound is lagging a little bit. I don't know if you're on an Ethernet or if your Wi-Fi. It's just I don't want to miss a single word you say, but
Sure.
it's starting to lag a little bit. So I don't know if you have another setting or because I don't want to miss a minute of this.
I apologize. I check my settings, but no, I'm on Wi-Fi at work, a
Okay,
very high-speed line. Is it
let's
still
just
lagging or is it okay now?
keep talking.
Okay, I was just making sure that was okay. I apologize for that, but
Right now it's okay. Yeah, I just don't want to miss a
okay,
single word of this because
yeah,
the thing is do you anticipate that this technology will be like the standard of care someday? Because right now it's a little bit expensive. Let's face it. You said it was in the $2,000 range, so I mean it's not
sure,
prohibitive for everyone, but a lot of people say, well, if my insurance doesn't cover it, I may as well just have
sure.
a surgical biopsy.
So we do have another test that was just released in the past month, and that panel is $899. And that actually screens for 50 solid tumor types, but it only works for a certain population. You have to have not had cancer in the past, and you have to have no symptoms of cancer. But the tests are expensive, but compared to a cost of the healthcare system, and I do get into that in my presentation, it's actually much less expensive to the healthcare enterprise as a whole. Additionally, when people have high deductibles, particularly five, six, seven, $8,000, these tests will actually be applied, even if they were covered by insurance in many situations, to their own financial responsibility. So yes, they're expensive. We do make an effort to keep the cost down. We offer patient financing without interest in order to make testing more accessible. And at the end of the day, we do sincerely want people to get better cancer care. The company, one thing I forgot to mention about the history of it is our company does not have any outside investors. The entire company from inception till now has been funded by one man, Rajan Datar, whose name is on the moniker of the company. And he founded the company. He's a very wealthy Indian fellow. He founded the company after his mother died of cancer. And it sounds like a made up story, but it's actually true. He made his money developing electrical infrastructure in India in the previous decades. And then he was looking for an opportunity. And he was inspired by his mother's death and the lack of diagnostic tests and the lack of therapy guidance tests that were out there. And he founded the company based upon that principle.
Wow, that's actually incredible. Do you worry, or I mean, not you maybe personally, but I remember talking to Dr. John McDougall about this, and his worry was it's different when somebody's been diagnosed with cancer, but like somebody that
Sure.
maybe has a history of cancer in their family and is one of those people that is just curious. They have no symptoms, they're in good health, they take the test, and you find cancer. Could that result in just overtreatment of something that would never have progressed to be a problem anyway?
You brought an amazingly interesting point. So what laboratory, not just us, but what others have been able to do is we can find circulating components of cancer in the bloodstream. And we ran a large clinical trial with 3,000 patients. And in that trial, we found patients that had circulating components of cancer in their bloodstream, but 1 year and 2 years later, a very small percentage of them never developed a solid tumor. And we know, in fact, I do discuss it in my presentation, that the body has a number of repair mechanisms that repair damaged cells, repair damaged cell DNA, actually prevent cancer from forming. This is something the body is doing day in, day out. Because the simple definition of cancer is that it's an abnormal cell that grows rapidly and out of control. That's the most basic biological definition you can have. So I wouldn't say that we can't need to unnecessary treatment, but we can identify things at a stage so early that a confirmatory process, say MRI or CT scan, do not show a mass, but that will more than likely appear within the next few months.
Okay, so Chad, it's not just me, but a couple of the viewers are saying your sound is breaking, and I just don't want this presentation to not be stellar because I know it will be. So I'm trying to think of a workaround. If you like, what with me when that happens, we just go to Ethernet, instead of Wi-Fi.
Sure. And
I don't know if you're at a place where everybody's on Wi-Fi, but it goes okay, and then every now and then you start. Like we're missing words and it's just not good. So I just it would
my
be
Yeah, because yours is actually cutting out now too as well. And I apologize. let me do this. Let me cut off my video and see if that fixes it. I just did a throughput test and it was over 100 megs, so it should be fine.
So now
But
you're fine. It's funny. Now you're fine.
yeah,
It comes and goes.
I apologize. I don't have a hardwired connection that I can plug into in my office. Everything is wireless. So I will turn off my video and hope that that resolves maybe the potential bandwidth issue that's occurring and kind of go from there.
Okay.
And see.
Good. Then
So
they, oh boy, then they got to just look at me, but okay. That's okay. You're still there though, right? Even though I
I
don't.
am. So hopefully that's improved. So
Okay. Well, guys, let me know if the sound breaks up. We're going to try this because soon he'll do a presentation. And so we won't have to see him at all. Why don't we go into the presentation now and we'll save some of these great viewer questions and some of the questions I have after we learn a little bit more about this, because I do want to expound on what you just said about will it result in overtreatment for people that
yeah.
didn't need treatment? Yeah.
Yeah, and I do talk about undue anxiety, which comes from the current standard for diagnosing cancer, as well as some of the things that we offer. So there's a lot of people that are undergoing procedures unnecessarily, and break into data on that and illustrate why people are having biopsies unnecessarily and why you might want to reconsider that when someone brings that to your attention.
Just so you know, the sound did break up with the video. So I think it's one of those things that's going to be like an intermittent thing with you, is my guess.
I am horribly sorry, and unfortunately, there isn't anything else I can do. It is not a cellular connection; it is a high-speed
I mean,
connection.
sometimes we have guests come in and out, like of Zoom, and you could try that. And I'll just talk to the audience for a minute. Do you want to try logging out and logging back in? That's the only workaround that I can think of, and then you'll start your presentation.
Absolutely, do that right now.
Okay, do it right now and I'll talk about something else. So guys, hang up there with me. This is too important to have words missed. So Chad is going to come back in as soon as he can and give a wonderful presentation. I've seen the slides. And in the meantime, I can't answer any questions on this topic. I did have a friend that had this done and it was very interesting, and we'll ask him some questions about this. Let's see. So let me just tell you about the show tomorrow. So tomorrow, 9 o'clock, we have two amazing lifestyle medicine doctors from England that are going to talk about what they do in the UK, as well as make an English breakfast. That's at 9 o'clock tomorrow. And then at 2 o'clock, we have a special show, a bonus show with Kathy Hester. She's going to do all things Ninja Creamy because the weather's getting warmer and everybody wants a creamy now. So that's good. And then Saturday, we have Dr. Jeff Pierce, who lives in Santa Rosa, who actually grows all of his own fruit, not all, but a lot of his own fruits and vegetables. And then Sunday, we have Chef Del Srofe. So if you'd like to know the schedule, please consider signing up for my email list at chefaj.com. And we send out recipes and fun stuff. And we also send out the schedule. So we're back to Chad. And so Chad, whenever you're ready, let me just do screen share and you can start your presentation. So it's almost like we're starting over.
Yeah, I apologize. I really just don't have control over all these variables.
No,
so hopefully
no,
this
listen,
fixes it.
listen, this happens to the best of us, so don't worry about it. And I'm going to pray to the technology gods once your presentation starts.
I will add to those prayers and hope there isn't a further issue. So, whoops, wrong screen. Okay, let me get there.
There you go.
Okay, everything good? Everything there?
So far,
Everyone's
so
visible?
good. Yep.
Okay, perfect. Just a brief history. I talked a little bit about myself and my role within my company. But in general, through my career, I've worked with over 50 laboratories across the world. I've had a lot of experience in, hold on a second, in seeing what's out there, seeing who's innovative, seeing who's not innovative. And I've been with Datar Cancer Genetics for a little over 6 years. I was actually the one responsible for bringing the company to the United States. I had started those negotiations and brought them in. My contact information is there. I'm very happy to not only talk about the products that we offer and what technologies we have, but I'm also happy to answer general questions that you might have about tests or other things. There's a lot of good things on the market, and there's a lot of things on the market that are questionable. And I'm an extremely candid individual and be happy to discuss one or the other. So feel free to reach out to me. I'll also show you my contact information at the end. The focus of this was to speak about how cancer can be improved through non-invasive processes. So basically, I'm usually referring to a blood draw. I'm going to keep it somewhat topical. I didn't want to get into hyper technical things unless someone had an interest in them. But in general, if I start talking about mutant allele fractions and primer design and a number of the other technical components, most people tune out. So I wanted to cater this to the average individual who is worried about cancer or who has had cancer. So just so you're aware, I can go into technical components, but I preferred not to. Comments and questions are welcome. Please pass those through the normal channel, and then I will address those at the end. What we're going to cover today covers the entire what I call cancer care continuum. That's basically understanding how can you identify cancer earlier? How can you do a better job of figuring out if you have cancer? Most people are using a few basic tools. How can you avoid a tissue biopsy? Or how can you justify a tissue biopsy? You know, not everyone needs an invasive procedure done. There are definitely things that you can do to avoid that. And then how do you ensure that if you do have cancer, you're receiving the treatments that are most likely to be efficacious? And the final component is, if you're in remission, how can you be sure that you're in remission? Traditionally, we're using imaging, but imaging has a lot of limitations. So we'll talk about how you can use another process to identify if you're in remission and staying in remission. The first and most important question is, how do you know if you have cancer? Cancer can exist in the body for months or even years before it's detected. And one of the greatest challenges, and I'm sure a lot of the audience knows this, is that cancer is often detected at a later stage. So most of you have a semblance of what you should be doing to detect cancer. If you're a woman, you're probably having a mammogram done. If you're a certain age, typically 40 or 45. If you're a male over 50, you're probably having a PSA done. And if you're over 40 or 45, you're probably being recommended you have colonoscopies done. But something you might be, unaware of is that these tests are only looking at a few specific cancer types. And cancer could obviously lie dormant in your body for a number of years in other locations. So I alluded to this earlier, but basically your body has a number of mechanisms that that prevent cancer from occurring. There's specific things called mismatch repair genes. These genes repair the damaged genetic material of cells. There's other mechanisms that tell cells to die off through a process called apoptosis. One of the hallmarks of cancer is that the cells grow uncontrollably and don't die in the cycle that they're expected to. Many of the people here probably remember Angelina Jolie about, 10, 15 years ago, had an elective mastectomy. In that situation, the reason she had that done is one of the tumor suppression genes, which is called a BRCA gene, was defective. And because that gene was defective, she had approximately an 80% chance of developing breast or ovarian cancer. So to mitigate that risk, she went ahead and had both her breasts removed. Now, I'm not saying that that's the appropriate care that every individual should have, but that's the power that your body has if these mechanisms are functioning properly to repair damaged cells, prevent cancer, and suppress tumors once they emerge in the body. So, one of my personal greatest frustrations is that cancer screening in the United States is much too complex of a process. You may or may not be aware of this, but in the United States, the most common cancers are breast for women, prostate for men, colorectal for both populations, particularly colorectal for a younger population that's growing in frequency, melanoma and lung cancer. And one of the limitations that we see in the US with screening is that there's tests for these common types. As I mentioned earlier, women have mammograms for breast cancer, men have their PSA levels tested for prostate cancer. You're supposed to get a colonoscopy every 3 years after 40, 45. But what do we do for the 100+ other types of cancer? Why are we not screening for kidney cancer, which has over 80,000 cases diagnosed per year, or pancreatic cancer, where we have 60,000 cases diagnosed per year? And the primary reason is it's not feasible using current protocols to do this. We can't send everyone to get a full body CT scan or MRI scan. We can't run 100 different blood-based tests to identify what markers of concerns are present. It's not plausible to the current healthcare system for this to work. And also, protocols haven't been developed by the colleges that guide the specialty physicians to isolate and identify these cancers. So there's a great deficiency. We're not too bad at looking for the big ones, but there's hundreds and hundreds of thousands of people here that are diagnosed with cancers outside of the most common ones. And that's what's concerning. So I wanted to provide a basic workflow of how breast cancer is currently diagnosed in the United States. And I'm going to assume that some of you may have gone through this, but the process is hyper complex and involves multiple physicians, multiple locations, and often spans weeks, months, or in certain cases, even years, depending upon if they put someone under what's called a surveillance protocol. And one of the biggest headaches is that women's breast cancer impacts over 300,000 women a year. Most women think that getting a mammogram is a great tool to identify cancer or a risk of cancer. The problem is that according to recent journal publications, the average radiologist is missing between 17 and 38% of cancer when they look at a mammogram film. And the primary reason they're missing it is either they're overworked or that the woman has fibrous or dense breasts. And if you have fibrous or dense breasts, you're in a particularly challenging situation. And so normally what occurs is if there's a suspicion of a tumor on a mammogram, the patient is then sent for an MRI. MRIs are great for identifying masses, but the problem is they don't tell you whether it's cancerous or not. What they end up doing is they end up being rated, and they give you a likelihood that it's cancer, something is similar to cancer, et cetera. But this is all very anxiety inducing to the patient. So you've gone through two steps, which could have easily taken 2 weeks, 4 weeks, 6 weeks to get these tests done, and you still don't have an answer. You just might know that there's a mass there. And then the next step traditionally is that you move into a biopsy. And biopsies come in a number of forms. So you have needle biopsies, which are less invasive, but it still has risks associated with it. And then you also have tissue biopsies or lumpectomies, where they're removing a large part of breast tissue. From a recent publication regarding biopsies in the Journal of American Medical Association, they found that 20% of women 40 to 49 years old were found to have malignancies or cancer in those biopsies. That means that 80% of people in the 40 to 49 age range did not have cancer. So we're getting 1 in 5 patients to the stage to be diagnosed through a biopsy. So, and then when it rose to the age of 50 to 59, only 32% of the women had cancer. So we're kind of at about 1 in 3. So there's a huge population of women that are undergoing invasive procedures that carry the risk of bleeding, infection, nerve damage, and a number of other potential complications unnecessarily, basically, because we're not good at figuring out if something is cancerous or if something is benign. Additionally, the provider performing the biopsy secures tissue that isn't representative of the cancer if it is present between 3 and 10% of the time. So between the problems of identification of the mammogram, the ambiguity of an MRI, and then potential surgical error, we have a lot of potential mistakes that could be made. And then the final step in most cases is if the tissue biopsy does show that you have breast cancer, you're typically having a PET scan ordered, which is where radioactive isotope is put into the body, and then an imaging study is done. But the problem is PET scans don't work well to identify small tumors. And when I say small, I mean less than 2 millimeters. So we have this entire workflow that costs an enormous amount of money, waste, not necessarily waste, but requires an enormous amount of time and travel and appointments. And then we don't necessarily end up with an accurate answer. So that's kind of the state of US healthcare. The breast cancer diagnosis workflow costs between $4,000 and $10,000. And AJ had mentioned that earlier about, well, these tests that you're talking about that are blood-based are expensive. They are expensive, but in the greater scheme of things, they cost less than the average tissue-based process of diagnosing cancer. And I can apply this same workflow to many other types of cancer: prostate cancer, liver, pancreas, gastric. They all have this very convoluted set of steps that the individual has to go through. And they sit there and they're anxious through this entire process, which is another thing that's very sad about the state of healthcare and cancer diagnosis. So, is there a better tool? Can we do a better job at identifying cancer early on? Can we remove some of these steps that people have to go through? And the answer is absolutely yes. But people need to understand the limitations of these tests because these technologies are new. But there is a way to do this. There is a test that we offer. There's some in the pipeline from other companies as well. But the future is getting better and better and better and brighter. And more people are going to have access to cancer screening through very, very simple processes, i.e. a blood draw. So and I want to do a quick side note on the stages of cancer because it's going to be relevant to my presentation in a moment here. But one of the things everyone knows that stage 4 is a bad prognosis for cancer. That means it's spread throughout the body and it's in multiple locations. Most people don't know the difference between stage 1 and 3, which is simply that the tumor's grown and it's connected to the lymphatic system of the body. But the majority of the population doesn't know there's a thing called stage 0. And stage 0 is a cancer that is so early that it doesn't even have a solid tumor. And I do need to put a caveat in. Everything we work with is solid tumor based. We don't work with blood-based cancers like myeloma, leukemia, and lymphoma. So, but there isn't such thing as stage 0 cancer. It basically means there's molecular components of the cancer there, but there isn't a solid tumor yet. So I just wanted to clarify what the general stages are because I'm going to be mentioning them later on. So I wanted to make sure there's a basic understanding. But there's a better workflow for screening and diagnosis. We can mitigate the additional imaging in most cases. We can mitigate the biopsy need, and we can mitigate the PET scan. We offer 2 different options that streamline this process, but we simply need 3 tubes of blood that require no special processing that can be ordered by any provider. So we're empowering everything from primary care all the way up to oncologists and pathologists. But anyone can order the blood test that's a medical provider and get the person an answer in 2 weeks, which is an enormous cost savings and time saving compared to the conventional workflow for diagnosing cancer. The one limitation, and this is what I was alluding to, our sensitivity or accuracy for our testing is between 90 and 99%. So I'll be candid, we do miss 10% of cancers, but those cancers are typically in that stage 0, stage 1, and it's not that our process has failed. But what we're missing is that we're taking 3 tubes of blood. We're taking a very small fraction of all the blood in the body. So we simply gathered blood where the representative markers of cancer are not present. And that's the big difference. So, but hopefully in the next 5 years, everyone will be working with blood-based panels. And then we don't have to worry about this convoluted tissue-based workflow. So this is an example of what our screening report would look like. This is a panel that we offer. I'm not trying to do the sale. I'm just trying to illustrate what's available out there. But this is an $899 panel. This will screen for 50 solid tumor types. We're 89% accurate across stages 0 through 4, and we have a less than 1% false positive rate. The thing that I'm most proud of, and one of the reasons I stopped working with other oncology laboratories in particular, was that we're just as good, if not better than, and I know it's a boastful statement, but we do a better job than people going through those steps of getting 1 set of imaging, a second set of imaging, and a biopsy. Our data supports that we are more accurate than the typical tissue-based workflow. And we're not perfect yet. We're trying to get to 99% accuracy and not miss some of those early stage 0 and 1 cases, but we're less likely to have a false situation than the traditional existing workflow. So I'm very proud of that. And then we have a second panel that is designed to, this is what AJ was alluding to, which is designed to replace the tissue biopsy entirely. In Asia and Western Europe, these types of tests are more widely accepted and much more widely used. The US is much slower to adopt new technologies, and sometimes that's great because they get vetted more thoroughly, and sometimes it's causing patients to miss out on things that would streamline their life and reduce suffering and reduce expense and get people into treatment earlier and have better outcomes. But the reason I threw this sarcastic comment in there is we will often supply a result that is blood-based and say 99% sure that this is lung cancer or this is pancreatic cancer. But the oncologist will say, the standard of care says that we need a tissue biopsy. And they will go do that tissue biopsy and they will hopefully get the exact same result. Well, they actually always get the same result if they grab malignant tissue. And then they will say, oh, I guess they have it. And then that will be the end of the conversation. But in the US, even with our diagnostic test, which is called TrueBlood, I'll show you an example report in a moment, the physician is still probably going to want a tissue biopsy in the majority of situations. So, but what AJ had spoken about earlier too is there are patients that aren't viable surgical candidates for biopsies. So there's people that have pre-existing health conditions. They're just not well enough to undergo an invasive process, particularly for brain tumors. And this is where we really excel. So I chose to show our diagnostic report for a CNS tumor or a brain tumor. In many cases, the standard treatment, if you have a mass in your brain, is a craniotomy, which requires a stay in the ICU, tens of thousands of dollars expense to the insurance. And it's something that I know I'm terrified, and I believe most people would be terrified of. But for brain tumors, we are 99% accurate at diagnosing them. We have proven this through studies with University of Michigan and the Imperial College of London, and we have a less than 1% false positive rate. The average neurosurgeon, if you actually have a friendly relationship, will tell you that they miss grabbing malignant tissue when they do a craniotomy or an invasive brain surgery procedure between 2 and 10% of the time. So we are actually more accurate with a simple blood draw than we are of a surgeon's hand. And that's something that we hope to change in the near future and remove that, because most neurosurgeons I speak with, they also don't want to be doing craniotomies for cancer diagnosis. It's not exactly on the top of their list as procedures that they want to be involved in. So, quick summary of the benefits on the screening and diagnosis side, because I'll still talk about therapy guidance and remission monitoring. But with blood-based tools, it's a much quicker process. You can go from not having a suspicion of cancer to being diagnosed or ruled out within 2 weeks. Any provider can order these types of tests. So it doesn't matter if it's your gynecologist, your gastroenterologist, your primary care, even a nurse practitioner can order this testing. And in many, many situations, this is more accurate than a tissue-based process that the average person would go through to identify these things. And as a whole, I know there's cost involved. I know it's technically fee for service, but if it's an $899 panel or the diagnostic panel, which is about $2,200, it's still less as a cost to the system than going through all those other steps that would typically cost $2,000, $3,000, $4,000, $5,000, $10,000, or even greater if it's a neurosurgery type situation. So, big question, and I wouldn't be surprised if one popped up in the comments. I don't all providers do this. I touched on it briefly, but currently the tests from any company, there's only a few out there. Currently, these tests from any company are not covered by insurance. That is slowly changing, and within 3 to 5 years, we expect our tests to be covered by insurers. It's a very lengthy, complex negotiation process. It's very frustrating. Providers typically don't have time to learn. Providers don't sit around and read medical journals anymore. They don't sit around and go to conferences. They're too busy seeing 30, 40, 50 patients a day. And the groups that dictate what specialists do, the American colleges of X, Y, and Z, are slow to update the recommendation. So it's not that the technology doesn't work. The issue is that there's other systems in play that dictate how care is handled. And these are the systems that are a little slower to change than the laboratories can develop. So one thing I wanted to touch on relating to cancer before I moved into the next section of therapy guidance is that there's what's called standard of care in the United States. These guidelines, when it comes to cancer, are set by the FDA, the National Comprehensive Care Network, and pharmaceutical companies to agree, are influenced by an organization called the American Society of Clinical Oncology. Standard of care approaches are trial and error based approaches. So if you have cancer type A, you're then given drug B. If drug B fails, then you try again doing drug C, and so on and so forth. This is the most basic way to phrase this is a trial and error approach. And this approach leads to poorer outcomes than possible and unnecessary cost and patient suffering. Precision medicine, on the other hand, which incorporates a huge set of different processes and tests, not just for oncology, but for many other types of medical treatment, identifies which treatments will be most likely to be effective initially. And this is based upon the composition of the cancer and, in many cases, the biology of the patient. This removes the trial and error approach and replaces it with tailored treatment options. So we're not going through trial and error. And this saves money, it saves suffering, and makes the process much, much more palatable in terms of treatment for the patient. This is the tricky question that I get all the time. I've been diagnosed with cancer. Is the standard approach care standard of care approach ideal for me? And in some cases, I would say, yes, you don't need precision medicine testing to identify the therapy option. If you have early prostate cancer, which 99% of are exactly the same, most patients do well with standard of care treatment and have a good outcome. But if you have stage 3 or 4 cancer, you have cancer that's recurrent. If your cancer has become unresponsive to treatment or refractory, that it started growing after it was stable, it was regressing, or if you have a cancer that's no standard of care, which they do exist, precision medicine could potentially be the difference between surviving terminal situation. And this is where the types of technologies really, really shine in those situations. So there's a number of different processes laboratories use to identify treatment options. In general, they fall into 3 basic categories. Percentages show what percent of patients can be helped with drug treatment targets based upon these processes. So genetic analysis of the cancer in an individual usually only leads to treatment options for about 10 to 30% of cancer patients. Patients with breast, lung, and colorectal cancer have the best chance of identifying treatment options through genetic analysis type products. Chemosensitivity is a process where you test the drugs that are proposed to be used or proposing to be used against cancer cells, and you record their cell death rate. The good thing about chemosensitivity is it identifies the targets and creates a structure that tells you which are most effective in a tiered method for everybody. So you get results 100% of the time on which of those drugs would be most efficacious. And the final process is expression analysis. This is a process that ties to precision medicine drugs, drugs that don't work in the same capacity as cytotoxic, which I'll explain in a moment. But you've probably heard of things like someone who had breast cancer and it was ER positive or HER2 positive. These are expression analysis processes. Expression analysis can be done on tissue. Chemosensitivity can be done on tissue, but it has to be live. And well, so does it. It needs to be live for expression analysis as well. Genetic testing can be done on tissue that's been in storage and no longer living. But the problem is getting that cancerous tissue and getting enough of it to run this testing. Once again, we're trying to mitigate the need for invasive procedures and getting fresh tissue. Also, cancer changes. It undergoes what is called molecular shifts. So you have a tissue sample 3 months ago, and your cancer may not be behaving in the same way it was 3 months ago as it is now. So it's important that you use a methodology that represents cancer at its current state. So that's why we're focused on blood, because we can blood draw at any time. And that will be representative of your current state of cancer, not state of cancer 3 months ago. So I included this in the last slide, but I wanted to define cytotoxic versus precision medicine drugs. When most people think of cancer treatment, they think of an image of their head of an unwell-looking person who's lost their hair, who's constantly nauseous, who's always vomiting, who's wasting away. Most of this originates from cytotoxic drugs. Until about 2 decades ago, cytotoxic drugs were the only treatment options out there. And the reason it's called cytotoxic is because they're universally toxic. The idea is that cancer absorbs more material, healthy cells. And so if we basically pump in these poisonous type of drugs into the body, that the cancer will absorb more and die before healthy cells and tissues do. Now, treatment's gotten much better since then with regards to the cytotoxic drug, but they still carry a lot of risk, a lot of side effects. But they're not as bad as it was in the 90s and 80s. And then precision medicine drugs, targeted therapy that fight cancer in a number of different ways. They help illustrate where the cancer is so the immune system can identify it and attack it. They impede cancer cells' ability to replicate. And they become common, very standard of treatment for many cancer types. And they often come with less desirable side effects. So most patients will see a situation where a cytotoxic drug is used in conjunction with a precision medicine drug. And oftentimes they are no longer needing to implement high doses of cytotoxic drugs in many cancer situations. So the first methodology to identify what treatment options might be perfect for as someone who has cancer is genetic testing. This is kind of the dime a dozen. Every laboratory does this. Harris, Foundation, Guardant. It's a very refined process. The problem is it only leads to targets, as I mentioned, for 10 to 30% cases. And then 20 years ago, the laboratory industry believed that genetic profiling would end cancer. Unfortunately, it's 2024 and that hasn't happened. But besides identifying treatment options, genetic testing does have some other ancillary values. It can help identify how aggressive cancer the patient has going to be. And it can also somewhat assess how well they're doing with treatment, whether the prognosis is improving or worsening. And then the components of cancer, the genetic components of cancer, can also be used to detect a recurrence when someone is believed to be in remission, possibly prior to the imaging could pick up that tumor. And then I mentioned chemosensitivity. This is a process where you take living cancer cells that are isolated from blood, you expose them to the potential drugs that are being considered for treatment, and then you record the rate at which they die. And then from this, you create a tiered structure that says this drug killed 80% of the cells, this drug killed 70% of the cells, this drug killed 60% of the cells. And from here, the oncologist can determine which drugs are most likely to be efficacious based upon their class and administer those drugs. So the reason I really like chemosensitivity is because it removes the trial and error process from the drugs that are most likely to create the undesirable side effects. These are the cytotoxic drugs. So they can also be used, this process, the chemosensitivity process, can also be used, which I'm going to guess this audience has a lot of interest in, to test the efficacy of non-conventional treatments such as vitamin C, mistletoe, resveratrol, curcumin, and pharmaceutical drugs that aren't traditionally in the oncology space, diabetes medications, antibiotics, certain statins. All of these potentially can have value in fighting cancer. So you need to figure out a way to assess them and see if that efficacy is there, and we've done that. Another thing that's interesting in cancer patients is through research, we've identified that lots of patients who have not had cancer and have not had treatment have resistance to specific drugs. Much like you've heard about antibiotic resistance, you can have chemotherapy resistance even if you're what's called treatment naive. And this is a very important thing to know, because imagine if you were to be diagnosed with cancer, you're given a treatment, and your cancer is immune to that treatment. This does exist in both treatment naive and patients who have been treated for cancer previously, and it's not that uncommon. We have done studies where we have seen what's called platinum resistant, which is a class of drugs, in 20-25% of treatment-resistant breast cancer patients. I mean, in newly diagnosed breast cancer patients. So it's important to know everything you can before you begin treatment, and that's something that we really, really focus on as a company. This is a brief video shot through a microscope of the chemosensitivity process. What you're seeing is the green are actually cancer cells. The markers on the left, one that says 5-fluorouracil, that's the actual chemotherapy drug. And then now we've moved on to carboplatin. But what we're doing is we're taking the cancer cells, we're diluting the drugs to the level that they would be in a body with a standard dose, and then we're exposing the cancer cells for 12 hours. And then at the end of that, we're recording what amount of them survived, and that's how we regenerate a chemosensitivity report, which I'll show you later on. But for me, this is the most amazing thing, because you're looking at the actual cancer cell, something that is trying to destroy someone's life. We are witnessing firsthand how drugs are responding. The technology has gotten to that level, which to me is quite impressive. So the last process you can use to identify treatment options in most patients is what's called expression analysis. I mentioned it can be done on live tissue. If breast cancer, it's commonly done for hormone markers, ER, PR, and HER2. Typically for lung cancer, look for specific mutations. These are referred to as ACK in most cases, mutations. But it's something that can identify targets. It typically identifies precision medicine drugs. It doesn't really have relevance for cytotoxic drugs. And it's not, when it is on tissue, I would say that oftentimes not every option is exhausted by the pathology department. And it's done blood, we throw everything we can at it to find treatment options. But standard of care protocols typically indicate that for breast, you do these 3 markers, for lung, you do these 3 markers. There's 10 other markers that could be tested that kill targets, but because of insurance or because of standard of care guidelines, it's often don't get. So it's unfortunate. But here's an example of what our therapy guidance reports would look at. It's an immense amount of information if you come from a molecular background. In general, I wanted to show that when we report medication, we look at both the FDA has approved in the National Comprehensive Care Network. That's what it stands for, NCCN. And then we also are the only company that I know of that reports label therapy based upon cellular composition of the tumor. There are often drugs out there that have a chance of being efficacious. The pharmaceutical company didn't take the time or money to test for every cancer type. This is particularly common in more esoteric cancers. Small cell lung, clear cell renal cancers, a lot of these that are common. Drug company doesn't bother doing trials for those. But we know that from molecular signatures of the cancer that the drug has a chance of being efficacious. So we will report out both. Additionally, FDA-approved drugs and NCCN drugs are typically covered by insurance, while an off-label would not be. So that's why we take the approach of handling it in two different columns. Additionally, we identify how people metabolize drugs. So this is referred to as pharmacogenomic pharmacogenetics. We can tell you if you take drug X and you have increased risk for kidney failure, that your provider probably needs to monitor your kidneys more often than the standard protocol allows. We can also identify if you process a drug differently, too quickly or too slowly. In that situation, your provider would want to modify how they are treating you. They want to adjust your dosing. And so you don't have basically an overdose of what could be a cytotoxic drug. And then this is what a chemosensitivity report. This was the little video that I showed you. So this is how we would create the hierarchy of the drugs. I know the numbers are a little strange, but we don't grade the responses like an academic scale where above 90% is an A, et cetera. In our platform, anything above 50% or near 50% is considered a strong response and a strong cell death rate. And then anything from 26 to 49% is considered an intermediate response and a potential drug to consider. So anything below 25%, we don't bother listing as a potential treatment. So this is what I was referencing about how these tools kind of tie together. You have your genetic information. I'll show you the expression analysis in a moment. You have your chemosensitivity data, and you end up with a very well-rounded treatment plan that gives you options for both cytotoxic drugs, precision medicine drugs, and you understand how those drugs are going to be processed by the body. So this is what expression analysis would look like when we do it on cells. If you're not a science nerd, this is probably not the most exciting thing to me to look at. But to me, it's very thrilling because this is a great resolution image of a single cancer cell and what expression is being shown. In this situation, we identified that the cancer cells are basically expressing for what's called increased angiogenesis, or the ability to generate vascular structures which allow them to take more nutrients in and grow more quickly. And then there are drugs, specific precision medicine drugs, axitinib and aflibercept, that stop that process from happening. So we've identified from this multiple precision medicine drugs that could be used in the treatment process. So why isn't all treatment tailored to the patient? So these processes are very new. Most of these have been developed in the past 10 years. Medical schools have just recently begun teaching these processes to students. The American colleges, which I've referenced earlier, along with the FDA and the National Comprehensive Care Network, are increasing their focus on these tests. They are recommending some of them, but they're usually the more basic genetic tests. The more advanced tests, they haven't made formal recommendations on yet. And much of this testing is not covered by insurance, which I mentioned early on. But unfortunately, a lot of things in healthcare are not covered by insurance, particularly when they're on the more innovative side. And then a lot of times providers are fearful of patient blowback. If a patient orders a test, no matter who it's from, and if a provider orders a test, no matter what lab it's from, and the patient gets a $10,000 bill, for example, afraid that the patient's going to come and yell at them. But the provider was really just trying to do, what was best for the patient. So that's the reason, some of the reasons why we're not using precision medicine and tailoring treatment for every single patient. But that market is changing and it is improving. And like I said, the next 3-5 years, these things will become more standard for many, many cancer types. So the final category is remission analysis. It's wonderful. You've gone through cancer treatment. You're believed to be in remission. And now you're more than likely put on what's called an imaging schedule. So they'll do some imaging, maybe 3 months in the form of a CT scan or an MRI, or possibly, but unlikely, an ultrasound. And then if that's clear in 6 months, they might do another one. And then maybe you'll be on a protocol where you're looked at every year. So there's other ways to do this process, and they're often more sensitive than the imaging process, because as I mentioned earlier, imaging typically requires a mass to be at about 2 millimeters before it gets detected. So there are ways you can look for the molecular components of cancer in the bloodstream and potentially pick up cancer before imaging would be able to do that. So as I mentioned a moment ago, the limitations are typically the size with imaging. And also something people don't usually think about is, but if you had, say, pancreatic cancer and you're believed to be in remission, they're usually only looking at the pancreas or the pancreas and the liver. They're not looking at your colon. They're not looking at your lungs. They're not looking at your brain. They're not looking at other parts of the body to see if the cancer could be in those other locations, or if you could have had a newer onset and you're back at square zero. And then I had mentioned the size concern. And then the intervals in between testing can make people very nervous. A lot can happen if you're on a screening protocol for a remission protocol that's a year. So during that time, you could develop another cancer, and that cancer could go all the way up to a stage 3 or stage 4 during that window. So there's a lot that could be done in that interim or in place of imaging. So the newer process that can assess remission is based upon the principle that tumors are constantly shedding material of their composition into the bloodstream. So tumors are connected to the bloodstream. This is something people often don't think about, because they think a tumor is an isolated, kind of encapsulated mass that just keeps getting bigger. But in order for it to live, it needs to be connected to the bloodstream to gain nutrients in order to support the protein synthesis and replicate. So by being connected, it's constantly shedding genetic material, complete cancer cells, and other things. This is also how cancer metastasizes or moves into other organs in the body. So the newer approach is to look for circulating components of the tumor in the bloodstream. And we would look for what's called circulating tumor DNA, or what's called messenger RNA, which is another genetic component. And we would also look for complete cancer cells that have been shed into the bloodstream. Now, this process can detect something before imaging, but it's not a guarantee that it will, but we will almost always find circulating components prior to a mass forming. It is currently the best standard to find things sooner than later. So, and this is what remission monitoring would look like for us. Once again, if you're not really a scientific person with a molecular background, this is a lot of information. But in general, this was a patient that was surveilled over 9 months after prostate cancer was believed to be in remission. In July of 22, we found a very small amount of circulating components. And then in January of 23, we found a slightly higher number. And keep in mind, all this was from a blood draw. And then in February of 23, that number increased, and we declared that he had fallen out of remission, that he had a prostate cancer recurrence. And what we do with our monitoring panels, our remission monitoring panels, is that if the person does fall out of remission, we provide the therapy guidance suggestions at no charge. And those are based upon the genetic fragments that we find in the bloodstream. So that's the end of my presentation. But one last comment I like to make is that cancer care decisions are absolutely yours. There is no one that can force you to pursue a specific therapy. There is no one that can force you to take a specific test. Please remember that it is your job to take care of yourself, and you make the decision. So if you're not comfortable with something, or someone isn't answering your questions, move on to a different provider and be comfortable with the decisions you're making. Cancer is the one word that most people never want to hear in their life. So educate yourself, reach out to the right people. And if you're not getting the answers that you're comfortable with, try to find someone else. And then once again, that's my contact information. If anyone wants to reach out to me, that number goes directly to my office. You can email me questions about operations and panels that we offer. I shouldn't say operations, but panels and tests that we offer. And then I'm happy to even answer questions about other laboratories. I'm pretty unbiased when it comes to testing. And like I said, there's great tests out there from other companies. Caris does some good work. Natera with their Signatera panel does good work. And I will absolutely acknowledge other companies that are doing good things. It's not just that we're the only player but we do a couple of very, very unique things. So thank you for taking the time to listen to the presentation.
Thank you, Chad. There's going to be so many questions I know from
Sure.
live viewers, and my moderator, Susanna, is collecting them. But I have a
Of
few
course.
of my own. So,
Sure.
like, I had never heard of this. And then I had a friend that used you and was diagnosed with cancer. And that's when he told me about you. And that's when I contacted you to be on the show. But how
Sure.
does anyone know about this? Because it's not like our doctors are recommending it.
Sure. So we don't obviously sell direct to consumer. The way that we're educating providers is typically at conferences. We attend a lot of specialty conferences. So we attend the National Neurosurgery Conference, the Gastro Conference, BGO. I met the American Society of Clinical Oncology. 25 publications pending with right now. We've had about 10 in the past few years. But as I mentioned, providers don't keep up at read journals anymore. They're just worried about surviving the day in most cases. So we do a lot of channels to reach providers, get the information out there. It's slow. We are going to start doing social media advertising. We're starting to provide some awareness through morning shows in California and Arizona as well. But with this type of testing, the weight of information it carries, we never want to be considered a direct-to-consumer company. We don't want the perception of the products to be questionable. We want this to be like a snake oil situation. So we are very cautious in how we reach out to people.
Thank you. So one of the top questions is can you come back with a better connection? Because it was going in and out, because it's a brilliant presentation, but there are times where it's completely clear. And I will send it to you, and you can hear for yourself what's happening. But one of the viewers on Instagram, Canon Queen, is saying, can one use their FSA or HSA to cover the test costs?
I believe so. So they do all credit cards. They can generate a super bill to send to insurance. I believe that you can do it, but I haven't seen a charge come in the past year for it, but I do believe we can.
Thank you. And there's a viewer on YouTube that's saying how testing for growth in non-small cell lung cancer tumor or reduction in size when treated by chemo or radiation to check for progress in remission. So if I understand the question, if somebody's already had conventional cancer treatment, can they still use your company to test for the markers you were saying if they're going to be in remission?
Correct. It's exactly what we call cancer monitor panel for. It's to assess from a cellular and molecular perspective, is the patient truly in remission, or do they still have components of the cancer circulating, or what would be called residual disease?
So what was the percent accurate that your test is? Did you say 99 or 96? What did I hear?
It depends which test it is. So on our screening test, which is meant for asymptomatic people with no history of cancer, for diagnosis, we're at 89% across all stages, 0 through 4. For our panel called True Blood, which is when you have a suspicion of cancer, say a mass on imaging or an elevated antigen like a PSA test, we're 96 to 99%.
What causes the false positive?
Well, false positives are way below 1%. Technically, the reason we could have a false positive is that we would classify a false positive as that we detect a very early stage cancer, even before stage 0, and that the body's own repair mechanisms end up resolving those abnormal cells. Laboratories have just gotten very, very good at identifying things. And that's why I caution people sometimes that you can't have undue anxiety, because we can pick up something, and other labs can too, like Cell Search, et cetera. But it doesn't mean you're going to develop a full-blown onset of cancer.
Right.
So
does it ever happen where somebody has something on imaging, like a tumor on a CT scan or an active PET scan, and then your diagnostics have said they didn't have cancer? Has it ever happened that way?
in the 6 years that I've been with the company, no, it's never gotten to that point. If there is a mass there and it is malignant, we're very, very close to 100%. So I have never seen one be missed.
So on the other way, when it says that somebody and they don't have cancer and it does that result in a person like having treatment? If they like, what is if the person is, if on those rare occasions where it's wrong, what happens with that person? Then what do they do? I mean, I would hate for somebody to have surgery that they didn't need.
No, we usually recommend that there is it's a complex question, but usually what we recommend, particularly in our screening panel for asymptomatic patients, is that they have follow-up protocols that are usually the more conventional protocols to confirm the diagnosis. But that's legally just to ensure that they do, because we can pick up, say we pick up a state, you used a lung cancer's example. Say we pick up a stage 0 case, the person has a lung CT scan, there's nothing there. So we don't encourage anyone to immediately move to treatment in 99% of situations. What is being recommended is that they follow up with other types of testing to confirm what we found. So, but we can pick it up, and that's why I caution people. Labs have gotten very good. We can pick up things very, very early. And sometimes we're months ahead of the actual tumor being detectable on an imaging study.
I could say that if I had cancer, I would honestly rather not know. So I'm curious if your customers are
Sure.
more the people that have already been diagnosed or had something on imaging, or the people that want to do the 899 just to check and see, because I would not ever want to do that test. I would
Sure.
want to know.
I would say that 90% of our business is therapy guidance and remission monitoring, and diagnosis when there's a suspicion present. But asymptomatic individuals, you're absolutely correct. I would say it's probably 25, 30% of people want to know everything they can about their health status, and the rest of the population just doesn't want to know and would rather have their head buried in the sand.
Right.
And
Well,
that's perfectly fine.
I just
So,
worry about those people that are doing it that are asymptomatic, that if they've done nothing, they would die with whatever they found rather than from it. But like you say, people have a
sure.
right to do whatever testing they want. One of the viewers
Yeah.
is saying, can the blood test for metastases in addition to primary tumors?
Very good question. So our true blood panel actually identifies what's called the second primary tumor. So there's a common pattern, for example, colorectal cancer typically metastasis to the lung. So if you're being treated for colorectal cancer and during your routine imaging, they find a spot on your lung, that we can identify whether or not that cancer is cancer, that's a malignancy. So we can absolutely define a second primary, and the person doesn't have to go through tissue biopsy. And that is one of the intended uses of the test.
Thank you. And people are saying, where can they get the test? So like some of the viewers are in Canada. Where can a person anywhere get this test, or do they have to live in certain countries?
We can, so as I mentioned, any medical provider who is licensed to order our testing, there's no cost set up anything, there's no complex process. We need to set a special kit, collect blood, but any provider in the US can do it. And we have a distributor in Canada that if whoever it is emailed me, I'd be happy to connect them with the distributor for Canada. We do all products as well.
Thank you. So testing for, does this testing check for any kind of growth? So if somebody like my friend who had the test with you and it showed that they had cancer,
Sure.
do they come back to see if things change? And this is somebody that doesn't want to have treatment, at least conventional treatment.
We don't have a test that quantifies whether the cancer is progressing or regressing. That's something that we're working on. So if we're diagnosing cancer, we're just giving you a binary answer. It's cancer, it's not cancer. But we can do a follow-up test that identifies new treatment targets if the cancer becomes unresponsive or begins to stabilize and no longer respond to treatment. So hopefully that answers that question. But we can't say that you're 80% better or you're 60% better or you're 20% worse. There isn't a tool that does that yet.
I'm curious, since you are in different countries, are there certain countries that are more interested in having these types of tests?
Oh yeah, in England, our tests are covered by the national health system. In Germany, yeah. So that's why I kind of insult the US healthcare system, because it's such a convoluted, complex process. No, we have insurance coverage in a dozen plus other countries, and these are becoming rapidly the standard tests. We actually have recommendations from the NHS saying for prostate cancer, you should use this test, going out to their physicians. But in the US, it's a much, much slower moving process.
Do you think it has to do with?
No, it's not money. It's just the US is so fragmented, and every other country is a single payer system where there isn't a complex set of commercial insurers and federal insurers. But in England, you just have to deal with the NHS. In Germany, it's a single payer system. So, and they're much more data driven. If you show them quality data and you show them economic impacts, they move forward with it. But in the US, it's a game. You have to play a game with the FDA. You have to play a game with the insurers. You have to play a game with these other governing bodies. It's much more convoluted.
So you
So
don't think money's an issue at all? Because like I think about colonoscopy that some doctors
Sure.
think the gold standard, where other people, some people don't want colonoscopies for a variety of reasons. Even if they believe in early detection, a lot of people cannot stand the prep that's involved and they don't want to do it.
Sure.
So now there's something called Cologuard, which,
Yep.
which is much easier for the patient to do, but the doctor doesn't make the same kind of money. So I'm not saying all
Oh,
doctors are like this, but what I'm saying is once your test is more affordable, or when your test is covered by insurance, if somebody
sure.
has to go through surgery and have a biopsy, that generates a lot more income for the doctor in the hospital than a simple blood draw, doesn't it?
That is very true. So just to reference, it is actually illegal in the United States to pay kickbacks to providers. It's illegal to financially incentivize them, and it's often illegal for them to bill patients depending upon state law. So, but what you're referencing is 100% accurate. There's a reason gastroenterologists don't see patients in the office as often as they used to. They're more often doing upper endoscopies and colonoscopies because it does make them more money. The reimbursement for an office visit is nothing, but the reimbursement for colonoscopy is much more significant. So there is that, I don't want to call it greed, but there is that financial motivation component. And you mentioned Cologuard, which is a great test. But if people have experienced Cologuard, the humor is that you run a Cologuard test, and they either find blood in the stool or they find genetic material of cancer, then they tell you to go get a colonoscopy anyway. So you're going to have it done no matter what. No one is going to work just off the Cologuard results. So the doctor is still going to perform that colonoscopy. But I think it's a great way to get more people screened. I think it's a great test for what it does. And it does remove that prep that you mentioned. But yeah, I think you're right. I think money's involved there and what procedures pay doctors more.
Of course, you can't predict the future, but because other countries do pay for this, do you anticipate a time, even in the far future, that the United States will do this? At least because I feel like it should at least be offered to patients, because so many people are afraid of anesthesia, or just, I mean, afraid of getting biopsies. And like you say, in there's certain locations that it's almost impossible. So do you think there'll
Sure.
be a time where this will be an affordable option that is covered by insurance for patients?
I think within the next few years it will be. And there are currently tests, but they only cover that genetic spectrum that I referenced or tissue-based expression analysis. So tests from companies like Foundation and Guard and Carrot, which are just limited genetic tests, they are covered by insurance. I will caution your viewers that if you have a panel called a Foundation CX1, which is a great genetics analysis panel, the problem will be if your insurance doesn't cover it, you're going to get hit with a $10,000 bill for that panel. So you really need to make sure someone is ordering a test for you and you're not aware of the cost of it, that doing their diligence on insurance, because you can get hit with very, very high bills. So
Thank you. Okay, so here's a question from Leslie, which is, I had one of these tests a few months ago after having surgery. It showed I have 0% of cancer and very low chance of recurrence. How do you determine the chance of recurrence? Is it based on the blood test?
it wasn't our test if there was a chance of recurrence listed. I'm guessing it's Myriad's test. I don't know if she's able to clarify. But Myriad uses a data model that speculates how likely you are to have a recurrence, I believe, within 10 years, but that's not us. We give you a binary answer. So I don't think it was our test
Yeah,
that would have done
well,
that. But
if you're still here, please type in the chat what the test was, and then
yes,
we can further answer. D says, nodules were found on my lungs last year. Doctor chose a wait and see approach. Now I've developed a persistent cough. Can this type of testing be done to confirm or rule out lung cancer?
absolutely. So that is one of our strong suits. We can diagnose lung cancer through our True Blood panel, and you can have your answer within 2 weeks. What your doctor is probably doing is adhering to the standard care guideline. Typically with lung cancer, they don't want to do a biopsy till a mass hits 8 millimeters in size, or about a third of an inch.
Wait, did you say
So
eight? Did you say 8 millimeters in size?
millimeters is the medical cutoff to become concerned, but the patient in this situation is experiencing exactly what I wrote. It's they're concerned and they have an answer. And you have to wait before insurance will pay for the biopsy. The math hits about 8 millimeters.
Nice, thank you. And here is a question from, I hope I say your name right, Brebuff. Is your blood test effectively a second opinion? If you have a 2 centimeter tumor based on a needle biopsy, is there a possibility that it's not a true cancer? And can your blood test, can it confirm?
We can confirm it, but I candidly wouldn't feel that if someone had a tissue biopsy and pathology says it's cancerous, it's unbelievably unlikely that they were incorrect. So we can absolutely do that and confirm it, but unfortunately for this individual, I'd say that that pathology report is probably accurate.
Thank you. I love this question from Ellen. Can you offer this test for our companion animals, for our dogs and cats? Oh my God, I might do it that. I might do it then. Because I've had dogs
I
with cancer.
I have this as a personal goal to be able to do this. I'm a big animal person. I have a rescue dog and a rescue cat. And the founder of the company, Rajan, has about 40 dogs that were street dogs that he takes care of personally. But we're so busy on the human side, we haven't had time to switch to the animal side. But it is, in all seriousness, something that is on my back burner to talk about in the next few years and see if we can do it, because everyone wants something for their pets, because pets don't have an answer for oncology. They're just, well, your pet has cancer now, and we're going to try a couple things, and it's a very unguided approach. But no, it is something we would like to potentially explore in the next few years.
Well, when you do, get back to me. I want you on the show because
Yeah.
that is just that because also they can't talk. So we don't
Yeah.
know what the symptoms are with them really until it's usually full blown, you know?
Yeah, and cats are the great hiders of everything. A cat seems fine until that last week, and I've experienced that personally, and it's heartbreaking. I would love to be able to do more for them, but we're wrapped up on the human side. But maybe in a few years we will talk about adapting this to animals, if even possible.
Does the test detect what stage a cancer is in?
No, we don't do staging, so we have the technology to do that. Staging is usually based upon imaging, and it relates to what I talked about earlier, which is the size of the tumor and number of locations it's in. So we don't have the ability to tell you the stage, give you the answer whether it's cancer or not.
That's interesting. My friend the reasons that we met that had the test because he did not want to, well, not that he didn't want to, his tumor was in such a tricky place that the biopsy would have been like either risky or require major surgery.
Sure.
He said that the oncologist would not accept is this a liquid biopsy? Would you call what you do a liquid biopsy?
But the liquid biopsy term's kind of been adulterated. A true liquid biopsy is something that diagnoses cancer or provides therapy guidance options. There's a couple different categories. I would call it a liquid biopsy. It's a general term. So,
Okay.
any question about whether they would accept it or not? Every
Wait,
single report we generate,
right now I just couldn't hear what you just said. So let's
uh,
let's pray
every
that.
single report we generate shows the percentage of sensitivity and specificity, which is the accuracy, false positive rate for that cancer type. And like I said, it's typically if we're diagnosing someone who has suspicion, it's usually 96, 90%. We're also licensed by the College of American Pathologists, which is the gold standard for laboratories, and also the Centers for Medicare and Medicaid. So there's no reason they shouldn't accept the result. But if they don't, I'm happy to personally speak with them and explain the science behind it, explain the data behind it. But there are providers that are really just old school, and they just
Right.
believe, well, this is the standard.
He could not get an oncologist to see him without a tissue biopsy. Isn't that crazy? They just wouldn't accept
Yeah.
it. But
Yeah,
that's nice to know. That's nice to know that you'll talk to the doctor. But the
oh,
question is,
absolutely.
will the doctor talk to you? That's the
No,
thing.
I spend hours every week, and we have about 70 PhDs and MDs on staff, and I can actually connect them with another physician. We have partners at Cornell, we have partners at Michigan, Wisconsin. We have well-known institutions that we have employees at that are MDs that we can connect them with that can peer-to-peer convey the significance of the information, how accurate it is.
Well, how come we don't see advertisements for this anywhere? Like I don't watch TV, so I don't know what commercial,
Oh, no,
like in a magazine. Like, how come do you guys
we
advertise at all?
We do, and that's what I talked about earlier. We're very targeted in what we do. We attend a lot of the specialist conferences. We do a lot of physician-specific marketing. We don't advertise to the public. It's not a direct-to-consumer product. I don't want anyone to understand that. It's like 23andMe. So we try to get the education to the providers, not necessarily to the general public, but we're going to start doing more shows with specific providers, and that'll help out. So in terms, particularly in the cancer sector and some of the more women-centric cancers, because that's the primary audience for those.
She said it was Guardant Reveal was the name of the test.
Oh, okay. Yeah, it's not us, but Guardant probably I don't know the Reveal panel specifically. I know GARD well. They used a mathematical formula based upon the genetic mutations that were present in the cancer to predict the likelihood to recur, but in no way is that a guarantee. No one could say that you're definitely going to have a recurrence in 5 years or not going to have a recurrence in 5 years. It's just speculative. But there's nothing wrong with it. It's just a piece of information for you to consider.
Great, thank you. Are there any oncologists that are not the ones that are on your staff, but just that you've encountered that are actually excited about this and want to start implementing this?
We have quite a few oncologists and hospitals that we work with. We're working on some situations with Houston Methodist right now. A number of the hospitals in California, Hoag, and a few other larger ones have some relationship with Sharp Hospital. We're talking with Dana Farber about doing some work with them in the near future, which is a well-known cancer institutions. You do have many oncologists as clients. It's just without that insurance coverage piece, the adoption rate is going to be much lower because no hospital oncology center is typically comfortable offering things that are fee for service.
Yeah. Let's see. Well, this is fascinating. And thank you. This is, for the people that are interested in it, they'll have your phone number, they have your email, and hopefully there's enough very clear information in this where the sound didn't glitch out that people can.
I'm so sorry.
Again, not your fault, but if we ever did it again, or if you wanted to re-record at least the presentation, I know you said you're at work, but do you have because what I've noticed, because I've been done over 2,000 shows, is do you have somewhere that you would have an Ethernet capability? Because then it's
do. If I were to record it out in my home office, I can also supply the presentation for you to post. There's no way of doing that. I can convert it to PDF. But my home office actually has a gigabyte fiber line that's hardwired, and I could do it.
Well, I will send this to you immediately after the show, and you can kind of assess whether what you think. And either way, I thank you so much for your work, for being on the show. And you probably don't know, because I'm sure you don't watch my show, but every guest gets 2 free bottles of California balsamic vinegar in the flavor of their choice. And I'll be sending you an email right afterwards. Just out of curiosity, once somebody has the test, is it a one and done, or do you what's like, do they have access to you? Do you ever follow up on them and see how they're doing?
Because of patient privacy regulations, I don't follow up with patients. I'm also not an MD, so I don't do that. But tests aren't really a one and done test, because if you're screening for cancer and you're asymptomatic, it should be part of your physical routine, just like mammograms, just like colonoscopies, et cetera. The diagnostic test is often one and done, though, because if we're going to diagnose cancer, you're treated, and then you're in remission, we hopefully never see you again, which is the end goal. And then therapy guidance, sometimes tests are reordered because the cancer shifts and changes, as I mentioned, and then you need new treatment targets. So sometimes patients, the simple answer is sometimes there's times where repeat testing is warranted, and sometimes it's not.
Do people ever come to you, like, let's say they've already been diagnosed through other means, but they want to find out, like you said, like which drugs or which supplements are going to be the most beneficial? Has that ever happened where they didn't come to you initially for the diagnosis?
Oh, all the time. We have our niche is patients that are unresponsive to treatment. We've had people who have gone through 11, 12, 13 rounds of treatment, and everyone has failed them. And then we identify some esoteric treatment combination that will be effective for them. So one of our strong points is actually identifying those patients that don't have good outcomes, and they come to us later.
Well, this is really fascinating. And when you get the PET screen done, please come back on my show first, because
I want it.
Yeah.
I have 2 older pets right now, and I wish I had something for them. And I don't think there's anything out there that I've ever seen or been presented with, but it is in the back of my mind, and it's something, because the founder is such an animal lover, I can maybe convince them of next time we talk. So
yeah, well, that would just be amazing, But I'm guessing pet insurance would probably not pay for it, huh?
we would need to get the cost down to like a few $100s somehow. So, and then there'd be an interest.
Right.
But no, I've had a dog with cancer, and we spent, I think it was $30,000 or $35,000 treating him. So
wow, that's a lot. I had a dog that needed knee surgery, and that was like $10,000. So yeah, I can imagine.
No, I told him, his name was Wilson. I said, as long as you're happy and doing what you want to do, we'll keep going. And he stayed happy. And then the poor guy ended up throwing a blood clot in his lung. and he didn't die from the cancer. It was really heartbreaking. So, but as long as he was happy and playing and doing what he wanted to do, we kept going.
Yeah.
So,
Do you ever, I mean, by the time people come to you, it's probably because they already have it, but do you ever discuss prevention at all for like future cancers?
I, I to a degree, because it's a really multifactorial issue, and I'm not versed enough to be comfortable, but I do know diet, obesity, certain exposures, medications, these are all our questionnaire for when we're processing tests, have impact. I can't conclusively say that if you eat this, you're going to develop cancer, or if you're an airline pilot, you're going to definitively develop cancer. But all of those factors absolutely can increase the risk of someone having a cancer onset. So,
Yeah, thank you. Last question. I can't see it because I think you're blurred in the back, but it looks like you have a beautiful piece of art behind you.
oh, yeah, I can't really move the camera because it's on a tripod, but I do have a piece of
Is it like a
kind of
Picasso? I mean, it kind of,
no. It's a local artist out of when I was living in Arizona. It's an impressionistic piece out of Arizona. So,
I'd love to know
but
their name because I am quite an art aficionado. So I have lots of beautiful
oh,
pieces on my wall. So, well, Chad,
actually,
yeah.
oh, I actually collect for when I'm traveling. I actually collect pop art and contemporary art. So my home is filled with it.
Oh my
Um,
gosh, then I gotta, what state are you in?
I'm in Denver now, is where I live.
Okay.
So
Then I'm gonna introduce you to an artist. If you like pop art, his name is Cooper Smith. I have two of his pieces. I'll do that offline though. So
oh, sure.
yeah, I think you'll like him. Well, thank you so much, Chad. This was really interesting.
Yeah, and I apologize for the technical issues. Unfortunately, it was out of my control.
Right.
So
Well, if you want to do this over, I can do the whole thing over. I'm happy to do that.
sure. Well, thank
Uh,
you, and thank your audience. And
thank,
I wish everyone good health and have a wonderful rest of your day.
right. Thank you, Chad. And if you guys want more information, he is available by phone and email. And thanks for watching another episode of Chef AJ Live. Please come back tomorrow at 9 a.m. Pacific time for Dr. Claire Day and Dr. Daisy Lund. They are lifestyle medicine doctors in the UK, and they're going to be talking about lifestyle medicine and making the best English breakfast. I don't know what people eat in England for breakfast, but hey,
Interesting.
England is one of the companies you said that covers this. So maybe I'll ask them about
Yeah.
it. Yeah.
We have a large lab and a large office in England. I'll actually be there in July. So, but I know what English breakfast is, and I'm very curious to what they're going to
Well,
suggest.
then you'll have to watch tomorrow. Now, they won't get the vinegars because the sponsor doesn't send them internationally. So we won't even mention that to them.
Okay.
Well, thank you so much, Chad. Take care.
Thank you. Bye-bye.
Bye-bye. Thanks, everyone, for watching.